events, and he is now presently the secretary of Cochin Ophthalmic Club, and I invite sir for his wonderful presentation.
Thank you very much. I'd like to thank KSOS and Dr. Srini Ereklon for this opportunity. My topic is neuro-ophthalmology emergencies. So these are some of the emergencies that we come across in our practice. Systemic hypertension, Dr. Rosemary has spoken about it, venous sinus thrombosis, idiopathic intracranial hypertension, all these three presenting as disc edema, giant cell arteritis, myasthenia gravis, posterior reversible encephalopathy syndrome. These are conditions that should be recognized and managed without much delay. And on your right, you have these: pituitary apoplexy, pupil involving third nerve palsy, carotico-cavernous fistula, intracranial tumors, subarachnoid hemorrhage, and traumatic optic neuropathy. The reason I put them in these two columns is the ones on the left can be managed medically most of the time. The ones on the right need radiological intervention or surgical intervention. And Dr. Naufal will be speaking to us about that. So I'd just like to bring to your attention just a few cases I've seen over the years. This is a case that Dr. Rosemary had shared, 35-year-old male with headache, 3 weeks. You can see that in addition to the disc edema, there are retinal changes. So whenever there are retinal changes, you need to think of systemic cause. And the cause was hypertension. But this is quite an obvious case, but some cases can be very subtle. This was a presbyopic age group gentleman. He had got new glasses, already on treatment for hypertension and diabetes, but with the new glasses, his headache was not relieved. And you can see just one splinter hemorrhage in each eye. And again, his blood pressure was not controlled, and that was the cause for his persisting headache. And again, Dr. Rosemary had mentioned, this is all cases of disc edema, bilateral papilledema. You should have an MR venography as well, and this case will show you why. It's a 35-year-old female I saw while working in the UK on oral contraceptive pill and a recent episode of diarrhea. So both these are leading to a hypercoagulable state. She presented with complaint of headache and double vision, and you can see a florid papilledema in both eyes, and she had a 6th nerve palsy. So fortunately we did MRI and MR venography, and MR venography showed thrombosis in the superior sagittal sinus and also venous infarcts. Venous infarcts are similar to a ischemic CRVO, where there's increased pressure in the venous system causing ischemia. And so the MR venography has shown the thrombosis in the superior sagittal sinus, and she had an anticoagulation treatment done, and fortunately that gave a good result. You can see there's a reperfusion in the superior sagittal sinus, and the disc edema and other symptoms are gradually resolved. Moving on, 28-year-old female, recent history of headache and a recent increase in weight, and then you always go back and ask the history. You can see the bilateral papilledema, no other retinal features, and then you can see this history of transient obscuration of vision. Weight was over 100 kilos, and of course these again need to be evaluated properly along with the neurologist, MRI, MRV, and she had all the typical features of raised IIH. You can see there are specific features in MRI that are seen in IIH, and she was managed appropriately. Most of the cases are managed medically, but some cases you need surgical intervention. But some cases of florid papilledema, again this was a case of IIH, all of the investigations were normal, but what you can see here, he actually presented with decreased vision in his right eye, and what you can see is there's some pallor of the right disc. Left side disc, you can see there is a marked disc edema, almost like as a champagne cork appearance. So this is actually what happened is an AION in a papilledema. So when there is this gross papilledema, there is almost like a compartment syndrome happening, and that leads to an AION. So it's an AION in a papilledema, and these patients again need urgent intervention. Sometimes medical treatment does not give a good response. They need some things like optic nerve sheath penetration and sometimes procedures to reduce the increase in intracranial pressure. Again, another patient I saw while working in the UK, 74-year-old female, presented with complaint of, her only complaint was she wears glasses. She cannot see the upper rim and the side rim of her glasses on the right side. She was so observant. And when you check the fundus, she can see there's disc edema of the nasal half and also of the inferior half of the optic disc, exactly corresponding with the field defect. And then you always go back, all cases of AION, you go back and ask the history of jaw claudication, polymyalgia rheumatica, and pulseless temporal artery. Temporal artery biopsy was done, and that showed positive, and she had a course of IV and then followed by oral steroids, and which gave a good result. Always keep in mind myasthenia, the great mimic. So this is a gentleman who presented with vague eye movements, and you can see a head posture as well. The reason I put it as an emergency is these patients sometimes can rapidly worsen with systemic symptoms. So very often when it's purely ophthalmological involvement, the blood tests come as negative. So sometimes you just give a therapeutic trial treatment, and you can see with therapeutic trial all the symptoms vanished. So again, this is something you need to liaise with the neurologist and manage appropriately. Last few cases, this is a case of posterior reversible encephalopathy syndrome. Again, these patients are usually systemically ill. They may be on several medications. They may have history of eclampsia, high blood pressure, maybe history of malignancy, some toxic drugs. So very often there's a systemic history is very important to identify the possible cause. And then they present with headache, blurring, dizziness, and vague complaints. Vision is very often markedly reduced. And appropriate imaging. Ideally, you can see what we do is that we do an MRI. And important thing is that they may have a normal fundus. So reduced vision and normal fundus, high blood pressure. This is the sort of situation where you need to keep this in mind. And MRI shows on T2 you get hyperintense areas, and also on the diffusion weighted imaging, the special sequence to see the blood flow to the brain. And you can see, especially in the posterior part of the brain, there's the occipital lobes and parietal lobes region. That's where you get the edema due to, and this is believed to be due to disturbance in the auto-regulation in the blood pressure control due to various causes. And this again is an emergency, because if delayed, it can lead to serious consequences. The other emergency we can come across is a traumatic optic neuropathy. This gentleman I saw, and he was brought within 4 hours of being knocked by a two-wheeler, and you can see this immediately has an altitudinal field effect. And in these patients need to get imaged with a CT scan. CT scan may show his bone spicules compressing the optic nerve, or they may show an optic nerve sheath hematoma. And in those situations, a surgical intervention, either say by a maxillofacial surgeon or an ENT surgeon, can give good relief to symptoms. So what I've tried to go through is different conditions. Most important simple things that we can do obviously is measure the blood pressure, go back to history where necessary. MR venography, in case all cases of bilateral papilledema, MR venography should be done. And CT scan in emergency situation, especially trauma, CT scan can identify any suspicious cause, and the appropriate management should be done along with the physician, neurologist, neurosurgeon, ENT surgeon, and oculoplastic surgeon. Thank you.
It was an excellent presentation and a very good set of cases. The imaging photos were excellent.